Bottom right. The little symbol that looks like a T. Yep.
Alright, so I'm Amy Wells, and I will be showing y'all my Independent Study Mentorship Fall 2020 presentation. My teacher is Ms. Daffern, and unfortunately I didn't have a mentor this semester, but I will be showing y'all Gastrocnemius Recession for equinus deformity and its relevance to patients with cerebral palsy. So there is a disclaimer. Some of the information in this presentation is originated from outside sources. I did not come up with all this information on my own. So ISM it stands for Independent Study Mentorship. It is an advanced academic course designated for students who mentor/research a career or profession in a chosen area. This student will create a unique plan of study, and they will receive an individual instruction. This course is ideal for self-motivated students with a passion for a particular area of study. ISM is a full one-year course/credit, and students must perform at a collegiate level. We did have requirements such as students must complete an in-depth study of an area of interest, as well as document their hours and complete a journal. And they need to make an online portfolio, as well as complete all required assignments and develop a final product and presentation. So the career that I'm researching is an orthopedic surgeon. So an orthopedic surgeon is a trained physician who assesses patients' deformities and injuries in the musculoskeletal system. They provide medical care through replacement and reparation surgeries, performing physical examinations, providing designated therapeutic and treatment plans. The surgeon is typically head of the entire orthopedic department. So you can see the muscular system and the skeletal system. So the topic that I have chosen to go over is gastrocnemius recession. So gastrocnemius recession is the procedure that lengthens the muscles and tendons of the lower back leg. This allows movement of the heel to adjust downward and the foot to rest in a more natural position. I chose this topic of study because I aspire to become an orthopedic surgeon in my future, and this procedure is very common, therefore learning it will give me a grasp of what to expect. So there is initial needed information. So what is equinus deformity? So equinus deformity is usually a secondary to shortening, retraction, or spasticity of the triceps surae. It may require surgical correction, and surgery for this deformity is one of the oldest in orthopedics. It was originally performed on the calcaneus tendon, but it has been changed to fit different patients' customaries, such as underlying diseases, severity of disorder, and the patient's profile. So the deformity restricts ankle joint dorsiflexion. So dorsiflexion is the foot being up, and plantar flexion is being down. So think of plantar flexion as stepping on the gas, and dorsiflexion as taking your foot off the gas.
And so this deformity would prevent which movement?
It would prevent dorsiflexion.
So which one is that?
That is the upwards one.
So it would prevent you from
Yes.
moving your foot up?
Yes.
Okay, just want to clarify.
Yeah. So there is some initial needed information too, such as the relevant anatomical descriptions. So the area of focus is the triceps surae. This composes of the gastrocnemius soleus complex. So the gastrocnemius is a muscular unit that comprises of two heads, such as the medial and lateral. The two heads converge into the aponeurosis that merges with the aponeurosis of the soleus. The primary function of this is to pertain to the ankle, plantar movement / flexion of the foot. This is located on the posterior superior compartment of the calf.
The what?
The posterior superior, or posterior superior.
What does that mean?
It's on the back, more towards the top of the calf. The soleus is the other muscle. This lies deep to the gastrocnemius. The anterior portion is occupied by the aponeurosis, which thickens distally as it goes down. This fuses with the gastric of the aponeurosis, or mix it up. This mixes with the aponeurosis of the gastrocnemius. So the aponeurotic faces of the two are in contact to provide a slipping surface between the two muscles. And is that done now? aponeurosis, or what it is, it's this dense white fibrous connective tissue. It's like a flat sheet / ribbon of tendon-like material. Its function is to anchor a muscle or connect that area the muscle moves to. And although I'm not doing the lumbar, we have very restricted laptops, so I couldn't find good pictures. So this was the best picture I could find of an aponeurosis, and you can see that it's white and fibrous. And so here on image 1, you can see the lateral head, and image 2 is the medial head, the gastrocnemius. And number 4, you can see how it is, the gastrocnemius is superficial to the soleus, and you can see it peeping on the side. Here's the aponeurosis, and on this one, you can see that the heads of the gastrocnemius have been taken down. And on number D, or letter D, you can see the soleus, and I'm assuming what A is the aponeurotic faces of the two. So there's an additional disclaimer. There are other treatments for the deformity that do not require surgery, but for cases that do require surgery, many procedures can occur that do not require involvement of the gastrocnemius and can instead pertain to alternating muscles or tendons, such as the calcaneus or the Achilles.
Can I ask another question?
Yeah.
Why would someone get this? Like, what causes it?
I will go over that in a second.
Oh, okay.
Yes. So I will be covering over 3 key points, one being the procedure, such as how many different procedures are there and how are they done. Key point number 2 being correlation with cerebral palsy, being why is this more present in cerebral palsy patients and what causes the deformity in them. And number 3 being the recovery, which is how long is the recovery and any special requirements or assistance needed. So without further ado, I'll start with this. So the different types of procedures are the Volpus technique, the Baker lengthening, the Strayer technique, and the technique of Bowman and Coach. So the Volpus technique, this is usually used for spastic equinus. While the patient is in supine position, a midline incision is performed longitudinal on the muscle junction. Close to this junction, an inverted V is made through the layers created by the aponeurosis of the gastrocnemius and soleus. Then the foot is forced into dorsiflexion, and separation of the cut edges expose the still intact soleus muscle. Next is the Baker lengthening. So the Baker lengthening, this is performed in the exact region as the Volpus technique. I already said the next one. It's performed in the exact same region as the Volpus technique, but a U cut is made in variation to the V, and then the same dorsiflexion and separation is applied as well.
What are they trying to do in these surgeries?
So
Are they just cutting the muscle?
they're cutting the muscle and attempt for it to separate, causing the foot to go back down, and then it'll heal with the foot being downwards, so the patient can walk normally again.
So they're trying to lengthen it?
Yes.
What goes between it? Just air when it's cut?
To be honest, I think it's just the aponeurosis. Maybe it like grows in between that, or scar tissue forms.
The cartilage holds it together?
Hopefully. I mean, I think so. There wasn't that much information I could find because I didn't have a mentor, so this was all the stuff I could find through all the websites. So next is the Strayer technique.
You're doing awesome. I hope you don't mind me keep asking.
No, you're good. So the Strayer technique, this is used for spastic equinus as well. When the patient is in prone position, a medial incision is made on the calf. This detaches the aponeurosis of the gastrocnemius from the soleus. And the foot is dorsiflexed and the edges separate, revealing the aponeurosis of the soleus, which may also be sectioned. After sectioning both aponeurosis, additional correction is made at the separation borders of the soleus. Since the sural nerve is in the surgical field of this, the muscle body does not get sectioned and paresthenia can occur if the muscle's too tight. So this picture that I have right here pictures illustrate your technique really well. So here you can see the aponeurosis of the gastrocnemius and the midline incision. So here's the gastrocnemius aponeurosis section. The foot was dorsiflex. You can see the edges separated, revealing the soleus aponeurosis. Here is cut, revealing the muscle junction underneath, and then the foot is then forced into dorsiflexion.
So I guess that's what's holding the muscle together. So
Yes. So you can see how right there in between your heel, like giving that extra like half inch. I don't know specifically how long.
So it's like that muscle is too tight, and so you're like
Yes.
constantly pointing your toes. And they
Yeah.
cut that muscle so that you can actually.
Exactly.
Huh. Interesting.
And lastly, wait. Yeah. I like went back a slide. And so lastly is the technique of Bowman and Coach. So for the Bowman and Coach, the aponeurosis of the gastrocnemius and soleus is approached with an 8 to 12 centimeter long incision on the upper middle third or on the inner side of the calf. The surgeons must be cautious not to touch the saphenous nerve or the saphenous vein.
what happens is,
I assume parasthenia will occur. The patient will lose feeling there. So in the created space of the dissected muscles, 3 incisions are made on both faces of the aponeurosis. So that would be 6 in total, 3 would being on the gastrocnemius, 3 on the soleus. And these incisions must be at differentiating levels to prevent muscle adhesion when it's healing.
oh,
The foot,
interesting.
the foot is then forced into dorsiflexion, and the recovery process is from there. So sad, none of my transitions are working. Or is it showing on there? I would like to, I don't know how to explain the slides. So, relevance to cerebral palsy patients. So, ankle equinus is being the first symptom of cerebral palsy where treatment was reported, as well as the most recognized symptom of cerebral palsy. This is diagnosed through gait studies, which is a physical examination of the patient's walk, and the doctor or the orthopedic surgeons will determine the equinus from there if they have it or not. This deformity in patients obtaining spastic cerebral palsy gained the attention of surgeons, beginning modern surgical / medical management of cerebral palsy. The causation of this is these patients obtain poor motor control, contractures of muscles, ankle joint contractures, and spasticity. So these are usually responsible for most of these cases. So why does this form equinus if you're thinking of it? Because yeah, they have the spasticity, but how does that create equinus to cause? So equinus position in most cerebral palsy patients is due to the spasticity and secondary and tertiary deformities that are created by it. Central reason for equinus from spastic ankles is due to the plantar flexors being 5 to 6 times stronger than the dorsiflexors. So whenever equal force is applied, the plantar flexors will override the dorsiflexors. Does that make sense? I don't know if I'm explaining it good enough.
You're doing awesome.
Okay.
Keep going.
And the plantar flexors overrule the dorsiflexors in all aspects of the ankle joint. In children with total body spasticity, the plantar flexor overpowers the dorsiflexor, this is being the predominant cause of equinus in the patients. And how long is the recovery? So the first 2 weeks post-operation, the foot is splinted. After these 2 weeks, sutures are typically removed and the patient is transferred to a cam boot. This is a controlled ankle motion boot, and this is removable, so it can be adjusted to the patient's weight bearing and mobility as they're progressing through their recovery and through their physical therapy program. The initial 6 weeks period post-operation, the foot must be maintained at a 90-degree angle while they're sleeping so that the tissue growth can grow in proper positions. And during the daytime, the cam boot is worn to recondition the limb through performed range and motion exercises. So for my product slide, I will show you all my tangible product that I made. This is being a handmade model replicating the distal portion of a leg in equinus position. On the dorsal side, structures of the triceps, serrae, and surrounding nerves will be revealed. And is that 19?
13.
Okay. So this was my product, and here you can see the sural nerve, which crosses down the middle. And I didn't have room for it, but you can see the saphenous nerve right here, which is cut off. On here, you can see the soleus lying underneath, the aponeurosis, and on the side being, this is the medial head of the gastrocnemius and the lateral head. Here's more aponeurosis on top. And you can see the foot is in equinus position, if this shows it good. So you can see how it's like if they were standing on their toes.
So what would this look like if they were walking?
I don't know.
So,
Right
yeah,
there.
it's actually called toe walking.
Yeah.
Mm-hmm.
I was saying that last night. My sister was like, "Don't call it toe walking."
No, that's actually the term that it is referred to
Oh my
as.
gosh, I'm gonna get on to her about that.
Mm-hmm.
She's a nurse too. She was like, "Oh my gosh, Amy, you can't say toe walking."
That's what it's called.
So we also are required to collect 10 artifacts, and usually this would be stuff with like your mentor and pictures of that, but I didn't have a mentor, so I collect artifacts from online, which is the tools that are used during the surgery. So
Probably a good idea, because I don't think you can bring a scalpel on campus.
yeah,
Surgery needle through.
yeah, don't think those are very school
I would get
appropriate.
in trouble.
So first is the scalpel. This is used to make incisions into the skin that are, I mean, it can be all different types of sizes, but this is a minimally invasive surgery, so it won't be bigger than probably this big. Next that is used, or what's probably used prior to the scalpel is the skin marking pen. This is a, let's see the word. This is a sterile skin prep solution, which is used to mark on the skin where the incisions will be made. So then the scalpel is used, and then from there an Army Navy retractor is used. These are used to help retract shallow, superficial incisions, as well as the white liner retractor. This is set against the edges of the cut to help pry it open and also help further more open the cut. A cryohemostat is also used. This is a surgery essential. It is used to hold the tissue during dissection, clamp tissue prior to cauterization or ligation. This is basically to help manipulate tissues. The Bakey forceps and Russian forceps are also used. These are both used to help atraumatic tissue grasping. The difference between the two is the Russian forceps. You can see they have a more rounded end, and then on the Bakey forceps, they're more toothed ends. They're more like pointier, so it just depends on what type of tissue they're grabbing, but it's both like similar. And, I can go with the electrosurgery. So the electrosurgery, this is also known as a cauterizing pen. This is used because it helps close off the blood vessels to help prevent bleeding while swimming. So the first initial cut will be with the scalpel, and then from there, they'll cut the fat and the rest of it with the electrosurgery because this helps a lot more cleaner operation. The doctors can see more because there's no blood, or it helps reduce blood.
What part of the skin would the fat be in?
The epidermis,
The epidermis is the top layer.
and then the dermis.
The dermis is the middle layer. And the hypodermis is
Hypodermis.
the one underneath it where the fat is.
Oh, okay. Alright, there's a long section to go. I haven't reviewed over that area yet. And then lastly, suturing needles are used. I believe there's 3 types of needles, but since this is for not like inside wounds or stuff like that, and this is just on a normal skin cut or wound, a suturing needle would be used.
You're 19 minutes.
And here I will show you on my website.
Wow, we have a website. How cool.
So this is basically the purpose of this is to showcase my ISM coursework and mentorship project. So here is my requirements of the journals. You can see the first and second 9 weeks. My mentorship logs, here's an example of one, and then the rest can be downloaded. My required ISM assignments, which include the goal setting form I had to create, as well as the research that was used for this. And up on here, you can see the rest of my citations. This will go for later. And my midterm presentation, if you click here, you can see my first draft of this presentation. And then leading to the final product and presentation, here's the invitation, which is what you received. And my product, basically being the uploaded images of my product. And this is what I was trying to replicate. And additional artifacts. So these could have been the same 10 artifacts that I put on my PowerPoint, but I wanted to include some other ones. So here is an image of what a patient having equine deformity would look like. You can see they're walking on their toes. And here is the image we looked at earlier of the operation of the Strayer technique. Here you can see the skeletal system, which is relevant to orthopedic surgeons. You can see the gastrocnemius muscle and the soleus, where they both lay on the triceps array. On this one, you can see the foot being forced into dorsiflexion. So that's what you can see when they say by it's forced, it's manually put. Here you can see the muscular system, which is also relevant. And it's in this end. So I also included this image. So A, B, and C are typically the procedures that I covered over involving the gastrocnemius and the soleus, but the other ones that I said that are differentiating that could pertain to the calcaneus or the Achilles, these include the myofascial lengthening and the tendotomy of the tendon Achilles and anterior transfer of tendon Achilles, the sliding lengthen of tendon Achilles, and the Z lengthening. And here is the chart that I was using to base my operations on, but mine was cropped. I cropped off the Z and the hook because those weren't pertaining to the gastrocnemius. And here you can see is another foot in equinus form to show you more what it's like. And I also included an image that shows the medial head of the gastrocnemius and the lateral head of the gastrocnemius, as well as the plantar muscle that I mentioned previously. This is often referred to as the freshman's nerve because many new surgeons believe that it's a nerve when they're trying to operate. And let me go back to the presentation. So in conclusion, I hope that completing this project will aid me in my path to entering the medical field. And by studying this topic, I will gain more of an understanding and more knowledge about orthopedics, thus guiding me one step closer to my goal of becoming an orthopedic surgeon. So I hope that this information is as fascinating to you as it is to me, and thank you for watching. Here's my citations, and that's all saying I have it more, but they're on my website. And is there any questions?
I have lots of questions. Yes, do you want to be still recording to ask questions? You want to stop recording?
It can be stopped recording. I'll stop it.